So our next speaker is Dr. Chandrahas. He was with me in our lab actually. He's my classmate. He was my classmate. So he did his PhD here from IIT Bombay with Professor Sundar. He's currently working as a faculty in GSFC, Gujarat. Okay. Chandrahas, please.
Thank you, Dr. Rakesh, for the introduction. I also thank the organizing team for inviting me. And it's been a great pleasure for me being here as it is my alma mater. So, all in all, I'll discuss about the liposomal nanotechnology in cancer therapy, present, past, and future. Actually, most of the things have already been covered, so I will not take much time. Uh, I think no need to say much about the cancer as it is the second world most cause of the death worldwide after cardiovascular. So that therapy started since 1940s and initially only drugs were being given injected into the body. So there were so much losses, damages of the healthy cells, so toxicity was very high at that time. So actually we can see in the picture that when we give the directly drug to the body, then it will go to the normal cell as well as to the infected cell, as we can see the tumor cell. So it affects the both of the cells. To avoid this, then people started thinking about the carriers, nano carriers. Then several types of carriers were investigated to date. And here today I'll discuss about the one of the carriers, and that is the liposomes. So briefly, I say that 1940 it started 1940 when first drug came in the market, nitrogen mustard, and it was given directly to the body, so it has very severe causes toxicity. Then 1948, 50, 58, various drugs came for various purposes, various kinds of cancer. Then 1995, first drug came, as already has been discussed in many slides, in many talks, doxorubicin, and it was liposomal doxorubicin. It is said doxil. This one also has been discussed. So actually, liposomes were discovered. We can say that by luck. It was not discovered intentionally. So Alec Bungham, he was working on the phospholipid bilayer. He was a physicist and also hematologist. So luckily, he saw that when he used lipids he dispersed lipid in the aqueous phase, then he observed that the formation of layer, and at that time it was said, I think, lamella or something, or smectic, something they used to say. Then soon there, even after many years, this one was not used for the drug delivery. This one was used for the membrane study, biological membrane study. Then soon they realized that this can be used to encapsulate hydrophobic as well as hydrophilic drugs. And then people started working on the various methods to prepare the liposomes so that they can control the size and other things. So this picture we can see that is that microscopy picture, FM, and that one is a cartoon, and other one is that showing the bilayer, TEM picture. So what we need to look when we talk about the nanocarriers. Size is very important, as I already said in many talks, in starting I think. So typical range lies in between 50 to 150, or we can say somewhere we see that 80 to 120, but it is around 150. It should not be very high, otherwise that RES or MPS system will be there. So that those phagocyte cell will engulf those larger particles, as it is they consider as foreign particles. And if a size is very small, then rapid clearance will be there through kidney. Yes, whenever we try to form the nanoparticles, we think that circulation should be long circulation. Otherwise, if we if we encapsulate drug and if we inject into the body, then if it is not going to the particular target, it is going to the whole body. So if that circulation is no long, then there will be loss. I mean that the drug will have toxicity on the body, or it will be clearance, rapid clearance. So we need to avoid that one. This we can see that what size we need. Tumor cell, when we talk, then that space is increased. In case of tumor cell, that endothelial cell spacing and blood vessel cells spacing inside the tumor cell. So spacing is increased compared to that. So we need to think about that particular size, not very large or very small. So accordingly we do. Several types of liposomes are there: anionic, cationic, and deuterionic. So all have different properties. Mainly we use deuterionic most of the times. Whatever we have drug to date, in most of the cases deuterionics have been used. In case some cases cationic can also be used, but it has problem of aggregate and others because it has cation positive charge, and in our body blood plasma proteins are there, so they have negative charge. So positive negative they interact to each other and the aggregate problem is there. And anionic lipid we cannot much use because that uptake will be very small because negative, and our tumor cell is negatively charged due to the mutation. So that will be repulsion. So there will be problem. So therefore, in most of the times we think about the neutral as well as sometimes cationic, especially in the case of mRNA the delivery. So several methods are there. I have mentioned only a few, but there are so many methods. One method in the morning was discussed by Professor Mahesh, packed bed. And other method we developed in our lab in Professor P. Sundar, that stationary phase diffusion method. So here, but I have mentioned only few. That thin film, that is very popular, old, classic. Even to date, that is very classic. And in industry, as just many talks, it has been said that this is only method or sometime homogenization. These two are used. And so the method is simple, that this is our, in this case liposomes are formed by, with the pre-formed bilayer. Bilayer forms everywhere, but here pre-formed bilayer is there, and other cases that bilayers form before liposomes. In the case of solubilization, either we remove the organic solvent or we reduce the solubility with the mixing. So all cases are very simple. That sonic acid extrusion are not the liposome formation method, but they control the size by sizing method. And then ethanol injection is old method. Microfluidic method is very popular nowadays, and people are working in this method to scale this so that we can use rather than other method. But even to date, there is no microfluidic method which has been used to in cancer therapy. I mean that for the COVID, in the case COVID, LNP was used. In I think SHM was used, staggered herringbone mixer. Paralyzation. It was they paralyzed several in one chip. They paralyzed the mixer and they used. But in the case of liposome, to date, I don't think I didn't find any method which has been used. But the future is very good because I found in just last 2-3 years some methods have been developed which in one method they have compared their method with the thin film hydration and they found that almost similar that production. So then evolution of liposome design, we can say that conventional liposome, this one also has been discussed, so I'll not take much time. That PEGylated liposome to increase the circulation time, then targeted liposome so that we can send the liposome at a particular target. It can go to the particular site and it can release the payload. It can go inside or especially inside the cell, endocyte, through endocytosis. Then multifunctional or smart liposome, that is also called one name is also there, was there in therapeutic or something was there. I saw in one PPT. Theranostic, I think. I'm not, it not coming in my mind correctly. But that one is used in nowadays, but still it is under research. So these are the some liposomal drugs which have been approved by FDA to date. Almost 10 drugs are approved, which are being used for different types of cancers, and these are under clinical trial. Actually, in all cases, some drugs have been discontinued. Like I think this doxil has been discontinued. I was seeing somewhere in USA or Europe. They have discontinued. Okay. What is going? So, what is the current challenges in cancer therapy? Actually, that liposome remain versatile because today we can see that several drugs have been approved. This is only in cancer case, but in other area also so many drugs have been approved by FDA and other agency. So their future is very bright. We can say they are very promising. Of course, LNP has come and COVID, yeah, it worked. And that one we can say that the variation of liposomes, not exactly structure-wise, but yes, lipid-based. So now, as I said, that concentration is on about the microfluidic. This is one of the conventional method where lipid solution is focused with the aqueous phase by controlling the fluid flow rate ratio, total flow rate, and aqueous flow rate and lipid flow rate. We look at all these things. These are the few modern techniques, variation we can say of microfluidic, like toroidal. First one is toroidal, then serpentine, then one is caterpillar, another one channelization. Parallelization I have not seen. I have not shown. That one is in the case of that similar to that what Dr. Professor Mahesh showed in the morning. IEL. What was the name, sir? IEL. What one you showed one device. So yes. That one was the another case. So these are few, and in the caterpillar is compared. Just I think 1 year back it was developed and it has been compared with a thin film. And in almost all cases that production is more than 2 kilogram per hour. And when we talk about the conventional microfluidic, then in almost all the cases we find less than 1 kilogram. In general, 100 gram to somewhere 800-900 gram per hour. When we say gram per hour means gram lipid per hour. So production of liposome, we are talking in terms of lipid. So evolving trend is now is shifting toward the we discussed that theranostic liposome, or we can say the smart liposome, multifunctional liposomes. So now research is going on this, that imaging. So simultaneous, that drug is liposomal drug is injected and imaging is done, so that we can see the progress of the effect of the liposome inside the body. But it is still under research, not in the practice. Several imaging techniques are there, like ultrasound, PET, SPECT, MRI, CT, X-ray, optical imaging. So accordingly, we use the that label to image. Then passive to active. Still, most of the liposomal drugs which have been approved, they are based on the passive targeting, not active targeting. So active targeting, that research is going on, and yes, if it is successful, then we can see that we can see lots of improvement, because in that case there will be less loss of the drug inside the body. Toxicity also will be reduced because it goes inside the cell. And in case of passive, it releases the drugs even outside of the near to the cell. So some drugs can go here and there. Not all molecules will be effective, we can say. PEG dilemma is another problem nowadays, and in some study it has been said that although PEG is very popular and it is very well established since 30 years, 1995 when Daxil was introduced, but now in last few years that dilemma is seen. Dilemma means that we can see the confusion. I mean that in one way PEG is good, that it is increasing the circulation. It is increasing the circulation, but on the other hand, it is reducing the release of the drug, because it is protecting the bilayer. So protecting the bilayer, so it creating the hindrance near to the cell. So that is the another problem. So we can say that our body get confused. So what happens in the first dose, it works. But when we usually use many times doses, then our body makes antibody. Antibody, one kind of a protein is there, IG. So immunoglobulin, something like that. So that in B cell, spleen somewhere, B cell produces that kind of antibody. When we give the next time the dose, then that antibody capture that, and in spleen or liver, that phagocytes engulf that. So it considers a foreign material. So that effectiveness is reducing now. So now that one is one of the case that causes the accelerated blood clearance of the PEG, ABC. So so people are now concentrating to avoid the PEG dilemma. There are several techniques, but it's again under research, and rather than PEG, they are using other kind. They are trying to use the other kinds of polymer like POX, P-sort 50 and others. We also have started working on one of the polymer, that P-sort 50 in just started the working to see the interaction mechanical property. We are just looking how it will change the mechanical that bilayer means that we can say it can increase the rigidity or decrease flexibility. So that we have started, and we'll look that how it will work. So other techniques are that cleavable PEG detached, that pH responsive, like we use cationic lipid plus we sometimes DOP lipid can be used. So DOP is a fused lipid, is called fused lipid. So it creates fusion to the cell, and then once a cell goes inside engulf endosome, so it can escape the endosomal. Otherwise, it can lysosome can destroy that drugs molecules, we can say, inside payload. So also that PEG chain length we can optimize, and other things. That doses, we can play with doses, and still strategy that can be changed, like stimuli-responsive liposome we can use, like as I said that cationic lipid if we use like CHEMS, something is there, cholesterol, what we say, succinate, polysuccinate, something like that. So that one is called cationic lipid that is used here in that case. That is pH sensitive actually, that work in the pH. So that tumor environment is that acidic now. So and that place we can say that destabilizes the liposome, we can say. Then now the trend is going towards the artificial intelligence. This is just in 2-3 years we can see some papers, and they are all working on the microfluidic plus artificial intelligence to control the size, so that that we can avoid the so many experiment hit and trial. And once we set the data from the experiment, we can provide to the that model, various kinds of model they have used. Then next time if we want suppose 80 nanometer size, then if we put our demand 80 nanometer, then that model will give the particular that parameters, what parameter we need to keep to get the 80 nanometer. So in that case, we can avoid and directly we can use that component rather than going for the experiment or something. These have been used by several research groups. Several types of microfluidic system, like first one is periodic disturbance micromixer. Mostly micromixers are there actually. Then microfluidic hydrodynamic focusing. Then microfluidic vortex focusing. Then staggered herringbone mixer. The rest are the same. Data set they have taken different. Their model is different. They have varied the inputs, TFR, FRR, lipid composition and others. Size, they have looked size and PDI, stability, three things. Encapsulation, I didn't find any, if any group did. Then their results are there. In all cases, what I noted that they reported that in one case that this one was found very good. Random forest was found very good in case of accuracy. Though this is just a starting, so not much research has been done on this. Just starting is there. So all in all, liposomes are very promising. I said that many drugs have been approved in case of cancer, but in other area also, and some are under trial. So the focus should be now to use the micro AI and microfluidics also to control. And if we get success to scale this industrialized level, then it would be good. And then passive to active, POX, other alternative to use to overcome the PEG dilemma. And then personalized and precision nanometers. Actually, it can come from the AI mostly. So now with this, I stop myself. If you have any doubt, you can ask.
Thank you, Chandrahas, for beautiful talk and wonderful slides.
Thank you.
So, any question? The floor is open for questions. Yeah.
Thank you for the talk.
Okay.
It was in depth with the history and all the steps, developmental steps. So I just have one question. Like you said, there is issue with PEG. So what are there any chances that there will be no issues with this also? Because human body can produce IgG even for this. So that is my question.
So we came here after 30 years. So it works for several years. And but we have to look that what we say that biocompatibility. It has been seen that in some paper that biocompatibility of some alternative biopolymers are better compared to PEG. So if biocompatibility is better, then that means toxicity will be lower if biocompatibility is better. So that's why we can try. But just this is starting. No group has reported that complete story. Even not in practice. I mean that just starting, they have just studied a few things only. So that's why that focus is there. And if you are saying it may be okay, but what if it works then? That is called the research. If it works, then it is okay. But yes, I mean that PEG still will be in picture. There will be, I just thought that some variation will be there. Like we can use that sensitive, PS sensitive or temperature sensitive, something we can inbuilt there. Then the PEG also can be used.
Any other question? So if there are no more questions, one more question.
So it was a very nice talk. Sir, I just wanted to ask, using these liposomal carriers, can you target solid tumors as well as liquid tumors?
Yes.
How can you make them more specific if it is solid tumors?
I think some drugs are there for solid tumor even have been approved.
Yes, but how will the liposomes travel to that specific organ where the tumor is residing?
That we can say that is spacing. We can say vasculature. That tumor cell that is spacing between cells is more compared to the endothelial normal cells. So that's why we choose particular size that can easily go to the inside the tumor cell. Tumor that lump, we can say that inside that. So that blood vessels, many blood vessels also go inside the tumor, but those vessels which go inside the tumor, that places, that spacing is more compared to the normal places. So
Okay.
that can go easily.
Okay.
That if you take that particular range, 100, 150 is whatever in that around 100, 150, 20, something like that.
Okay. Thank you, sir.